Dr. Castanet. Today I'm going to explain a problem called spondylolisthesis. This is literally a slip of the bones or vertebrae in your back, typically in the low back, but it can happen in the neck as well. It typically happens from a couple of different possible reasons, but first let me define what it is. I'm going to use a spine model for that purpose. These represent two vertebrae in the low back. Again, this could be true in the neck, but it's more common in the low back. So we'll pretend for the moment that we're discussing this problem in your low back. These are two vertebrae. There's a disc in between and disc above. Of course, there would be additional vertebrae below and additional vertebrae above. What it means, spondylolisthesis, is literally spine slipping. So when you hear the term slip in the context of the spine, it's typically an older expression meant for the disc, pertaining to the disc, such as a slip disc. We don't call them slip discs anymore because that's not a very good description of what disc problems are. In fact, it's rather misleading because discs don't slip, but in fact they herniate and bulge and degenerate and collapse. But with respect to the spondylolisthesis, we're talking about a slip of the bones, not the discs. So ordinarily, if you look at the vertebrae like this, these two bones would line up, and they would line up properly with respect to this border back here, the bony border, the back part of the border. And we can see that on X-ray, and we can see that on MRI scan. In fact, for the purposes of diagnosing this, it's better done on X-ray with the person standing, which is the way X-rays are typically done in the low back, rather than with an MRI scan where the person is typically laying on their back. Because when you lay on the back and there isn't the weight of the torso on the spine, the slip may look normal. It may not be appreciable. Usually it is, but sometimes it's not when you're laying on your back. So it's better if you load the spine in weight bearing, and you're more likely then to see the slip of the vertebrae. The reason this happens is for a couple of different reasons, potentially. In the first and probably less common case, there's often a defect in this little part of the bone between the joints. The joints are responsible for maintaining the bony relationship so that the bones remain in alignment. And when there's a defect of the bone here, which can happen congenitally or more commonly probably as a stress fracture in our youth, then this break between the joints doesn't permit the joints to do their job, and then this body of the vertebra, the big bony component, will slip forward on the vertebra below. If it slips just a little bit modestly, maybe a millimeter or two, it may not make much difference, but that problem tends to be slowly progressive as you age, so that at some point it can become a problem. If it's a significant break and defect here, and it's present on both sides, then sometimes even in our youth, as children or teens, it will allow the vertebra to slip far enough that it'll become a problem. When this slips too far, there is only one appropriate solution for this, and that is to surgically pull the bone back in place, jack it up in place. We put a little bit of what we term a cage in there, and we fuse the two bones together so that they are and remain in alignment thereafter. You have to have appropriate alignment, because if they slip, then the holes that house the nerve roots don't line up properly, and if the hole doesn't line up properly and it's askew like that, then it's going to traction the nerve roots into the canal. What also happens is you get shear forces on the disc in between that cause degeneration of the disc, and typically then the nerve roots will be tractioned over that defect. But in any case, that's what spondylolisthesis is, this slip. I just described the first and less common cause of it, which is a defect of what we call the pars interarticularis, meaning the part between the articulations. So this pars defect allows slippage of the two vertebrae or of one vertebrae on the other, and that's a cause of this. But the more frequent cause is that as our spines age and degenerate, these joints themselves can become deformed and arthritic and degenerated, and the joints which are responsible for restraining the vertebrae and holding them in appropriate alignment, they can become incompetent to do their job. When they become incompetent to do their job, the shape of these joints becomes deformed, and then they become incompetent, and one vertebra will slide forward on the joint, which is not doing an effective job at restraining and holding this vertebra in place. There are other anatomical components that maintain appropriate relationship, such as ligaments, but those are stretchable. So over time they will stretch, and they won't provide the appropriate restraint and alignment of the vertebrae. In that case, if the slip becomes too much, meaning typically probably more than 3 to 4 to 5 or 6 millimeters, which is, you know, anywhere from, say, an eighth to a fourth of an inch, then it'll be incompatible with painlessness and ability, and it'll become progressively painful, and you'll become progressively disabled by it. And then that will have to be fixed surgically. These problems in an older population, say in their 50s, 60s, and 70s, are probably present in maybe 10 or 15% of patients that present to spine specialists for treatment. So it's a very common entity, and like I said, if it's a modest amount of slip, these people will generally respond to treatment and do fine without surgical intervention. In my experience, they respond best when they're non-surgical to the treatment that I commonly do for neck and back pain, and that is spinal decompression, because there is a collapsing relationship here. There's impingement of nerves, there's degeneration of discs, and generally that's best treated with spinal decompression. In fact, that's probably also a good litmus test for when people are surgical. A lot of times you'll see people and diagnose these problems, and you don't know with certainty whether or not they're surgical or not. So you treat them with non-surgical means, whether that's physical therapy, which I find at some point won't be effective, or what my treatment, which is non-surgical spinal decompression, which is more often effective. And then if those aren't effective, you can offer them injections, which may be effective, but often are not as well. But that's how you figure out who's surgical and who's not. You do it empirically by trying different things, and when they fail to provide sufficient improvement, then you've figured out who's surgical. And surgery for that has a very good prognosis, because in that circumstance, if you have just the one problem and it's easily identifiable, and if you've determined that they're not going to improve with non-surgical treatment sufficiently, then in all likelihood they'll do very much better if you do treat them surgically and you fix the slip and you stabilize it so that it's in a better relationship again as it was before the problem started. So that is the entity of spondylolisthesis. If it's minor, I can help you. If it's not, I can get you to the right person to do a fusion, which may be done minimally invasively and has a very good prognosis. If I can help you with your problem, my number is 404-558-4015, and I am in the Decatur, the city of Decatur, which is a little suburb in the Atlanta metro area. Thanks very much. Bye-bye.